Hello, everyone. Welcome to the Preemie Health Talks. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, and your host for this event. The Preemie Health Talks is the first of two international live series that CPBF is hosting 2020 in recognition of World Prematurity Day. Next month, we'll be hosting Preemie Power Week, and all the information is already available on our website. All the sessions are free, and you can register to those sessions already. The education sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANS, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With the Preemie Health Talks and the Preemie Power Week, we intend to bring you the guidance of healthcare professionals and knowledge gathered by researchers around the world, which are extremely valuable to help us care for families and their babies. I want to thank AbbVie for the unrestricted educational grant, Pampers, and our amazing team who worked really hard to organize this event. And today we have two sessions. One is starting now with Dr. Bosco Paes and followed by Marianne Brack right at 1 o'clock. So Dr. Bosco Paes is going to talk about the burden of respiratory syncytial virus illness in healthy premature infants. His presentation will focus on the impact of respiratory syncytial virus infection on healthy preterm infants less than 35 weeks gestational without comorbidities such as BPD, congenital heart disease, and pre-existing medical conditions. Dr. Bosco Paes is a professor emeritus in the Division of Neonatology, Department of Pediatrics at McMaster Children's Hospital and McMaster University. He has received several teaching awards and he has been recognized for his academic contributions by the President at McMaster University and the Pediatric Chairs of Canada. Dr. Paes' current research interests focus predominantly on RSV in children and thrombosis and hemostasis in neonatal population. Dr. Bosco, thank you so much for joining us here today. What a pleasure to have you here this afternoon.
So thank you for that kind introduction, Fabiana. And I'd also like to thank the Canadian Premature Babies Foundation for the invitation to present. So I am going to get started. So my talk, as Fabiana has already addressed, is the burden of respiratory syncytial virus illness in healthy, and I'd like to specify that because my target presentation is really going to be just on the healthy premature infant. So here is my disclosures. And most importantly, I will be addressing the CARES trial, and we got some investigator-initiated funding and a grant from AbbVie for the trial. So my objectives today are to review the burden of RSV infection in preterm infants and examine the impact of the new AAP guidelines on the morbidities and costs incurred through RSV hospitalization, determine how to target RSV prophylaxis in late preterm infants. Here we'll be talking about infants between 33 to 35 weeks gestation and slightly younger cost effectively, and review the stress of RSV hospitalization, more importantly, on family lifestyle. So this study was conducted by Dan Stewart from Louisville in Kentucky in conjunction with the American Academy of Pediatrics, Fetus and Newborn Committee. And you can see on the x-axis the gestational age of the infants, and then on y-axis the percentage of births in the US in 2017. And overall, preterm infants comprised 10% of the annual birth cohort. So if we look at the global incidence of RSV, lower respiratory tract infection worldwide, it is approximately 22%, and it accounts for 33.8 million episodes of RSV, lower respiratory tract infection globally. And out of that, 3 to 4 million children with lower respiratory tract infection episodes require hospitalization. Overall, as you can see on the right side of this pictorial, 40% of RSV hospitalizations occur in infants who are less than 2 months of age. And I think it's important to appreciate that 79% of the hospitalized children have been previously healthy. On the left side of this picture, and you will see the mortality rates. And overall, the mortality rates estimated are roughly between 66 to 199,000 in children aged less than 5. And the key risk factors contributing towards that mortality are immunocompromised children, those of very low birth weight, less than 1,500 grams, and HIV. And I think it's important to appreciate that 99% of all the deaths occur in low-income countries. So this is the first large study that was conducted looking at RSV hospitalization based on gestational age, and it was conducted by Tom Boyce in Rochester in the years between 89 and 93. On the x-axis, you will see the chronological age of the children, and on the y-axis, the RSV hospitalization rate per 100 child years. And you will recognize that, in fact, the highest incidence was in children between 0 to 5 months of age. And this is very consistent across all the studies. But also appreciate that when you look across the various gestational groups, shown here based in blue, less than 28 weeks, in orange, 29 to 32 weeks, and 33 to 35 weeks, in fact, the hospitalization rates remain persistent up to 2 years of age. And overall, RSV hospitalization in preterm infants in this study without prophylaxis was 2 to 3-fold higher than term infants up to 2 years of age. Moving fast forward 13 years later, this was a study conducted by Caroline Hall in Rochester, which also included patients from Cincinnati, Ohio, and Nashville in Tennessee. And they examined RSV hospitalization rates among children less than 2 years of age. If you look at the third column, you will see that the incidence rates in term infants was 5.3 per thousand. And in the lower gestational ages, they ranged from 5.1 to 19.3 per thousand. And overall, what you should recognize is that in the lower gestational age groups, the incidence was higher, but also recognize that the difference in incidence was not that significant in patients between 29 and 34 weeks gestation as compared to those who were very preterm, less than 29 weeks. Overall, from this study, preterm infants had a 3.5-fold higher risk of RSV hospitalization when compared to term infants. A more recent study from Alison Helfrich from the Walter Reed Military Hospital in Bethesda, they looked at the hazard ratio, which is shown here as HR with the 95% confidence intervals, in infants who were overall between 0 to 2 years of age. And they compared the hazard ratio for RSV hospitalization in those between 33 to 34 weeks, 35 to 36 weeks, versus term infants in the last column, and the term infants with the reference group. And I've drawn a horizontal line across the slide to show you yet again that perhaps the relatively high hazard ratios for RSV hospitalization in the preterm group between 33 to 36 weeks compared to term infants, but also appreciate yet again that the RSV hospitalization hazard in fact extends well beyond 6 months in the study and remained relatively high even at a rate of 2.27 in infants 35 to 36 weeks gestational age between 12 to 24 months. So I just felt that this was an interesting study to show you because it looks at RSV hospitalization in preterm infants based on birth weight in Peru, which is a middle income country. And you'll see in the second column, the birth weight of less than 1,000 grams, and in the third column, 1,000 to 1,500 grams. And what I want you to appreciate is that for birth weights less than 1,000 grams, once these infants were hospitalized, the ICU days, the total hospital days, the days on continuous positive airways pressure, and mechanical ventilation in those less than 1,000 grams was much higher than those between 1,000 to 1,500 grams. So this tells you that the lower the birth weight of the premature baby, the greater the risk of incurring morbidity once they're hospitalized. And more importantly, when you look at the RSV hospitalization rates in those less than 1,000 grams, they were 2.7-fold higher than those between 1,000 and 1,500 grams. So now I'd like to turn my attention to the RSV hospitalization rates among preterm and term infants before and after the changes to the AAP guidance that restricted prophylaxis in 2014 to preterm infants only less than 29 weeks gestation. Prior to that, the AAP recommendation was to give premature babies up to 35 weeks gestation prophylaxis. So let's see what effect this had in terms of restricting the prophylaxis to infants less than 29 weeks. This study was conducted by Evan Anderson from Emory University in Atlanta, Georgia. And this was both a retrospective and prospective observational study involving 46 US sites between 2014 and 2016. The first thing to appreciate is that the patients recruited, 99%, as you can see in the green circle, had acute community-acquired RSV. And if you look at the breakdown of those infants, as shown here by the various subcategories of 29 to 32, 33 to 34, and 35 weeks gestation, you can see the percentages that were recruited. Overall, 45% of these patients who developed RSV were admitted to the ICU, and 19% required mechanical ventilation. Of note, of the kids, all of these kids that did not receive prophylaxis, 2 deaths occurred, which is very important to recognize. And overall, for infants aged less than 6 months, this accounted for 78% of RSV hospitalizations, 84% of ICU admissions, and 91% of those requiring mechanical ventilation. And this slide shows you the distribution of the patients based on the morbidities that they incurred. And again, this is looking at the breakdown of the infants based on gestational age. In light green, 29 to 32 weeks. In dark blue, 33 to 34 weeks, and in orange, the 35 weeks gestational age. And at quick glance, you will appreciate, if you look at the bar graphs, that the highest incidence was in the lowest gestational age, but the overall incidences remained quite high in terms of ICU admission, even for those between 33 to 34 and 35 weeks gestation. Similarly, the need for mechanical ventilation was highest in the lowest gestational age group and was quite consistent at fairly high percentages for those between 33 to 35 weeks. Not surprising that the corresponding ICU length of stay in days was highest in the lowest gestational group, as was the total hospital length of stay. And this graph shows the same data, as you can see on the x-axis, the chronological age in months of the children that were enrolled in this study, and on the y-axis, the events that occurred. And what I would like to emphasize to you is that overall, the highest incidence yet again was in infants less than 6 months of age, with a distinct peak for infants who were less than 3 months chronological age. So if you look at the hospitalizations, the ICU admissions, and the mechanical ventilation for the time period of the study, they all showed the same time peaks. And not surprisingly, therefore, based on the admission rates, the costs for these infants once they got hospitalized was relatively high. So you can see, based on chronological age, the purple bars are those for infants of 3 months, less than 3 months chronological age. Those between 3 to less than 6 months were in deep blue, and in the lighter blue for those between 6 to less than 12 months. And overall, you can see the costs were very significant for those of lower chronological age, irrespective of whether they ranged in gestational age between 29 up to 35 weeks. And again, it's important to appreciate that the costs remained relatively high for those with older chronological age between 3 and up to 12 months. And those costs varied between 30,000 up to almost 70,000 across the enrolled patients. So again, relatively high costs following hospitalization for all these kids who did not receive prophylaxis based on the new guidelines. So this is data from Leonard Krylov from the Children's Hospital Center in New York, examining more or less the same group of patients before the guidelines changed, which was 2011 to 2014, versus after the guidelines were changed between 2014 and 2017, based on the gestational age as shown on the x-axis in the various bars. So the total number of patients that they examined who were preterm were just over 12,500, and they examined term infants, and those amounted to 320,000 patients. And as you can see on the y-axis, the percentage of patients receiving palivizumab. So before the guidelines were changed, you can see the distribution based on gestational age, and those who received prophylaxis, especially those between 29 to 30 weeks, was up to 64.7%. And after the guidelines changed, you can see the dramatic decline between 2014 and 2017 in terms of the receipt of palivizumab. And by the time you get to 33 to 34 weeks, only 0.3% of the patients from the enrolled group were receiving prophylaxis. So what happened? You can see that the preterm RSV hospitalization risk was 55% greater in 2014 to 2017 versus 2011 to 2014, when prophylaxis was being administered as part of the guidance. What happened to these preterm infants in terms of morbidity? Here you can see the distribution again between 2011 and 2014, which was the era prior to the guidance change and after the guidance change in 2014 to 2017. And what you notice was that the RSV hospitalization rates, the length of stay in terms of hospital, and the ICU admission rates was significantly higher after the guidance changed, and that was statistically significant, as you can look at the p-values there. There was also a higher incidence in terms of the need for mechanical ventilation and costs, but this did not reach statistical significance. So what happens to these children after they get RSV? And this was a study, again, looking at the same population and the costs in US dollars for morbidities incurred after the RSV hospitalization. And what this graph shows you is the 5-year difference in the all-cause cost burden between the RSV infected infants and control infants who did not have RSV. And you can see the difference in costs based on the gestational age, early preterm defined as those between 24 to 28 weeks, preterm, as shown in yellow, between 29 to 34 weeks, late preterm between 35 and 36 weeks, and the term infants in black who were greater than 37 weeks. In brackets, you can see the numbers enrolled in each part of the cohort. And overall, as you can see, the costs, not surprisingly, were highest in the early preterm group, who in fact suffered a lot of respiratory morbidity after they had acquired RSV in the first 5 years of life. So what were these morbidities? So you can see at the bottom of the slide that the physician and emergency room visits were higher in those who were exposed to RSV, and most of these visits occurred in the first year of life, that contributed to the significant costs. Subsequently, asthma and wheezing occurred in 10 to 18% of the total 5-year general practitioner visits. So it shows you that the costs remained significant to the healthcare system after these preterm infants developed RSV as compared to the control group. So I'm now going to show you data very similarly in Quebec in Canada, because Quebec, the Ministry of Health decided to follow the CPS guidelines and discontinued RSV prophylaxis for late preterm infants between 33 to 35 weeks gestation. And this occurred in 2015. So what you see in the green bars is the era prior to the discontinuation of palivizumab. So children who received palivizumab between 33 to 35 weeks in 2013, 2014, it was 2.5%. In 2014 to 2015, it was 3.3%. And the overall percentage of the kids who received palivizumab in this gestational age cohort was 2.9%. And after prophylaxis was discontinued between 2015 and 2017, you will see in the yellow bars the corresponding number of patients who did not receive palivizumab. So overall, 3.4% of all infants between 33 to 35 weeks after 2015 did not receive palivizumab versus 2.9% with palivizumab during the time period of the study. So what happened to these kids? Very similar to the US Sentinel study that was conducted by Evan Anderson, which I've just described to you. This slide shows you the baseline characteristics and the morbidities incurred in these preterm infants, which numbered 130, compared to the term infants, which numbered 234. So not surprisingly, similar outcomes. The ICU admission rates were much higher in the preterm infants as compared to the term infants who did not receive prophylaxis. The length of stay was correspondingly higher in hospital. The need for mechanical ventilation and intubation was correspondingly higher in the preterm infants. The number of days on continuous positive airways pressure and the number of days on oxygen in the preterm group, shown in the second column, was substantially and statistically higher than the term infants in this study. This is a very important slide, again emphasizing the costs incurred in this late preterm group in the Quebec study who did not receive RSV prophylaxis. And what you will note is that the average total direct and indirect costs incurred during the hospitalization were much higher post revision of the guidelines. So approximately $29,000 per patient in 2015 and 2017 because they did not receive prophylaxis, versus $16,900 for those who did receive prophylaxis between 2013 and 2015. And these costs were substantially higher also in the preterm infants compared to the term infants after the post-revision of the guidelines. So you can see the costs there, $29,000 versus $10,000 per patient. But the most important take-home message from this study was giving prophylaxis in Quebec to the late preterm infants between 33 to 35 weeks gestation held a cost advantage. Therefore, it was more important to prophylax these patients to avoid hospitalization due to RSV, lower respiratory tract illness. And in fact, it was an advantage to the healthcare system to actually provide prophylaxis to these late preterm infants. So we know that prophylaxis has been well delineated to reduce RSV hospitalization. And this is the IMPACT trial. You can see the x-axis, the gestational age of the infants, and on the y-axis, the hospitalization rates percent. Compared to the placebo, which is shown in green, and in palivizumab, the patients who were randomized to that part of the treatment strategy. And overall, you can see across all gestational age groups from the IMPACT trial, the reductions in RSV hospitalization were very significant and ranged from 73% for those who had 33 to 35 weeks to up to 80% in the rest of the preterm population, showing you that palivizumab was definitely a useful strategy to adopt to reduce RSV hospitalization in the preterm population without BPD. So if we examine and go back to the data in the US in 2017, which I showed you at the beginning of this presentation from Dan Stewart's study, preterm infants between 32 to 35 weeks gestational age comprise 8.4% of the total birth cohort. So in the US, this approximates to approximately 3.2 million children. So you can see if we offered prophylaxis uniformly to all infants between 32 to 35 weeks, it will be very, very costly. So in Canada, we developed a risk scoring tool for late preterm infants between 33 to 35 weeks gestation. And you can see the 7 variables in this risk scoring tool and the scores given based on waiting for RSV hospitalization in this second column. And the total score amounts to 100. And what we do in Canada, based on this PICNIC study, PICNIC stands for the Pediatric Investigators Collaborative Network of Infections in Canada, is if you have a score after birth and you are between 33 to 35 weeks gestation, and the score ranges between 49 to 100, you are eligible for prophylaxis. Now, why did we do this? This slide shows you our study conducted by John Sampalis from Montreal. And what you see is this wonderful curve in this slide. So I'm going to show you this curve. And this is called a receiver operator characteristic curve. And what it does is it divides the scores on the x-axis into 3 categories: low, moderate, and high risk for RSV hospitalization. So if you have a score between 0 to 48, your risk of RSV hospitalization is 1.7%. So it doesn't make sense to offer these children prophylaxis because you would be giving a huge number in the low risk category who have a very low risk of acquiring RSV prophylaxis, because it wouldn't be cost effective. Once you get into the moderate risk group with a score between 49 to 64, you can see that the RSV probability for hospitalization increases to 7.1%. And once you get to a score between 65 to 100, your predicted probability of being hospitalized with RSV climbs to 18.7%. So it makes good sense to prophylax infants in the moderate and high risk group. And if you look at a study that we conducted myself locally in Hamilton, the moderate risk group in terms of the 33 to 35 weeks comprise approximately 13% of this cohort, and the high risk group amounts to approximately 6%. So the total percentage of patients in the 33 to 35 week group is roughly about 19%. So we've developed this very nice risk scoring tool to target prophylaxis at those infants who truly need it in this gestational age group cost effectively. So now I'm going to turn my attention to the CARES study, which was conducted as a prospective observational registry across 32 sites in Canada and amounted to 25,000 patients who received prophylaxis between 2005 and 2017. Here you see the distribution of the centers who were involved in this study, and I'm sure you'll appreciate there was a very nice generalizable distribution across Canada from the West Coast all the way down to the East Coast. So we had good representation, and therefore the data is generalizable to the whole of Canada. And what we found was that 56% of the patients who enrolled were male, 68% were Caucasian. The patients were enrolled at a mean gestational chronological age of 5.7 months. The mean gestational age of the patients was 32 weeks, showing you that the largest group of patients enrolled in this study were preterm infants. And the mean number of doses that the children received over the RSV seasons between 2005 and 2017 were 4 doses. So overall, what you see, and I'm going to focus on prematurity because that's the target discussion for today, you can see that the respiratory illness hospitalization rate was 4.3%, while the RSV hospitalization rate in the preterm population was 1.1%. You can also see the distribution in congenital heart disease and in bronchopulmonary dysplasia, which I won't discuss today. But overall, the RSV hospitalization rate in this entire study was 1.6% and is one of the lowest rates in the world for children who received palivizumab, with the consideration that we had a large population who had serious medical disorders also enrolled as part of the registry. I'd like to turn my attention now in the last few slides to discuss the impact of RSV hospitalization on families, which I think is an often forgotten entity and really is very important to recognize for the families of all these infants who get hospitalized, irrespective of their gestational age. But I'm going to discuss the preterm infants in the majority so that because this presentation really focuses on the preterm population. So this study was conducted by Ian Mitchell in Calgary between 2010 and 2012. And what they enrolled was all preterm infants, I should say, between the 33 to 35 weeks of gestation who had not received prophylaxis. So these were the infants in the low risk group who did not meet the risk score for RSV prophylaxis. You can see that the need for oxygen following hospitalization was a little bit higher in the term infants as 96.3%, compared to the preterm infants at 92.3%. When we look at ICU admission, the preterm admission rate in the ICU was much higher than the term infants, green versus a red. When we looked at the hospital length of stay in this study, not surprisingly again, because the admission rate was higher for preterm infants, the ICU length of stay was correspondingly higher for the preterm infant group. When you look at the stay in the pediatric ward, it was a little bit higher for the term infants compared to the preterm infants, which is the red bar versus the green bar. And if you look at the total hospital length of stay, there was a little difference in terms of days between the preterm and the term infant. The average length of stay for the patients admitted for RSV in the study was 6.5 days. Now I'm going to turn the attention to the impact on the family. And the first graph I'm showing you describes absenteeism, which is absent from work during the time period of the RSV hospitalization. Presenteeism implies that the parents were working, but in fact their productivity was reduced. The overall work impairment is a combination of absenteeism and presenteeism. And activity impairment describes impairment of activity outside work. What you see in this slide is based on overall work impairment, fathers were slightly more impaired than mothers, while compared to activity impairment outside work, mothers were more compromised. Recognize also that the numbers in this study were relatively small. Then they looked at stress and how stressed were these parents once these premature babies or term babies were admitted to hospital. And you can see, and not surprisingly, the highest stress was on the working mothers compared to the working fathers, as shown in blue. And the last thing they assessed in terms of stress was a state anxiety. State anxiety looks at past, present, and future feelings of worry, apprehension, nervousness, and tension. in parents. And you can see that state anxiety here, again, not surprisingly, was higher in the mothers as compared to the fathers. Trait anxiety expresses current feelings based on personality traits. And again, working mothers were more affected than the working fathers. And that is what everyone would expect. So I'm now going to turn attention to exactly the same outcome measures, but this was in the Sentinel study as described to you earlier on from Evan Anderson of the infants between 29 to 34 weeks gestation. They also assessed absenteeism, presenteeism, decreased productivity, and daily activity impairment shown in the various lines across this for the various gestational age categories between 29 and 35 weeks gestation. And you can see for mothers, notice also that the total numbers in the study were relatively high at 212. You can see mothers in this study, not surprisingly, were greatly affected, and the highest scores were at the time of discharge from hospital, and not surprisingly, all those scores correspondingly dropped post-discharge from the hospital and were lowest at 1 month post-discharge. Similarly, for fathers, the scores were highest at the time of discharge and progressively fell to 1 month post-discharge. But overall, again, not surprisingly, when you look at the productivity assessment, the mothers fared far worse than the fathers in all domains once their kids were admitted to hospital with RSV. So overall, the message that I want to portray is that caregivers experience greater stress and anxiety and poorer health, family health and functioning compared to controls. And the health and functional status of the hospitalized children was also poorer than the control group. There was significant family distress if the child was admitted to hospital with RSV, and this extends beyond the discharge period, maybe even beyond 1 month of age. Most of the studies only looked up to 1 month of age post-discharge home. And the group from Spain, Carbonell Estrani, and his team did this excellent study in Spain and in Italy. And what they found is that some of this anxiety could be alleviated for the parents by improving parental interactions and relationships with healthcare professionals when the children were admitted to hospital, and enhancing parental confidence about the ability of physicians to manage their child's RSV illness, which I think are important points to take away for us as healthcare providers. So I think in my final few moments, I would like to share with you a little bit in terms of once you got RSV, how does this impact your respiratory function? So this was a study conducted in 2013 by Sarah Kodeka from Cardiff in the UK. And what she did was an analysis of 59 studies that were published between 1964 and 2000. And the preterms were assessed between 5 to 23 years of age overall in terms of their lung function. And what they found was healthy preterm infants, again, I'm going to emphasize that, healthy preterm infants without underlying comorbidities such as BPD have a deficit in their lung function as expressed by the forced expiratory volume in 1 second, which is FEV1. And this was approximately 7.2% less compared with term infants. At the bottom of the slide, which I will not discuss for you today, but just to appreciate, that these deficits are even higher in preterm infants with bronchopulmonary dysplasia, whether they are assessed at 28 days of age or at 36 weeks post-menstrual age. So their deficits, because they have underlying lung abnormalities following BPD, is much, much higher. And this is a very interesting study conducted by Martinez's group in the United States. And what they looked at was children in terms of their lung function when they were older, into almost the third decade. And what they found was interesting. If you look at the left-hand side of the slide, there were two trajectories. This is the normal lung function trajectory, and they found a lower lung function trajectory in 56 infants. So they then traced these infants back, and all of these infants had spirometry done at 11, 16, 22, 26, and 32 years age. And what they found was the maximal expiratory flow at functional residual capacity was much lower in the infants with persistently low lung function. So trajectory. So in fact, you can see that these infants with a lower trajectory also had impaired lung function in infancy. And when they trace these infants back, surprisingly, those with a lower lung function trajectory had experienced RSV in infancy. So what this is telling you is once you get RSV in infancy, it perhaps sets you up for compromised lung function that may extend well into adulthood and may set you up for chronic obstructive pulmonary disease, which is an important entity to recognize. And I would like to then end my presentation with a piece of good news for all the families and caregivers. So just published is a new study looking at a new monoclonal antibody called Nirsevimab for RSV prevention in preterm infants between 29 to 34 weeks gestation. And you can see that it showed that there was a significant reduction in RSV hospitalization. In fact, 70% for all medically attended RSV lower respiratory tract infection in those who received Nirsevimab. And when you look at RSV hospitalizations, exactly the same reduction in RSV hospitalization, showing that it was 78% for those who received Nirsevimab. So why am I saying that this is good news? It's good news for parents and caregivers because this is a monoclonal antibody that requires only one injection at the start of the RSV season to protect the infants completely during the entire RSV season. So this is very good news. And they're now extending the study to encompass all premature babies less than 29 weeks and those greater than 34 weeks. And hopefully over the next 18 months, this product will be licensed for use and will take its place and supersede the use of palivizumab. So I think this is excellent news. So I would like to end with some take-home messages. I hope I've shown you that all preterm infants, inclusive of the late preterm infants, which have now been overlooked in a couple of the position statements, such as the American Academy of Pediatrics, and also in the Canadian Pediatric Society. These infants, if they do not receive prophylaxis, are at high risk for RSV hospitalization and incur substantial morbidity once they're hospitalized with concomitant healthcare costs, which are significant. We also have seen that the socioeconomic burden and family stress associated with RSV hospitalization in preterms infants is highly significant and bears attention. And as I said previously, it's something that's easily forgotten and overlooked by healthcare professionals because it's, it's something that's considered lower on the list, but I think it should be given more prominence and recognized. So overall, infants between 29 to 35 weeks gestation, in my opinion, based on the evidence, merit RSV prophylaxis. Late preterm infants who had highest RSV hospitalization risk, so i.e. those between moderate to high risk, should be targeted for prophylaxis. And the evidence is very strong based on the published literature, and in fact is outlined in this publication of a position statement by Manuel Sanchez Luna from Spain. And I was part of this collaborative group that published the evidence for RSV prophylaxis, which was clear-cut in terms of outlining the recommendations based on the level and the strength of the recommendations, level of evidence and strength of the recommendations. Thank you, and I shall open it up for questions to Fabiana, who has probably got a couple of questions that you want to ask.
Thank you, Dr. Paes. What a great presentation. You can stop sharing your screen so people can actually see on a full size.
Okay.
Dr. Paes, first of all, I really want to thank you for this because, as a parent of a premature baby, my son actually qualified for RSV prophylaxis 2 years in a row because he did come home on oxygen. He had chronic lung disease. So I'm very grateful for that. But nevertheless, he did spend time in a hospital and in ICU because of pneumonia, bronchiolitis, and other viruses. And I fully agree with you that we should give more attention to families and the impact of hospitalization to families, because you talk about work for moms and dads, you talk about the stress and the anxiety, because it does stay with us.
Absolutely.
And I think what is very important is to remember that families spend a lot of time in the NICU is already a big level of anxiety. And then we get some education that the baby might get sick again and what we need to do to prevent some illnesses, and that anxiety live with us, especially if you have that first readmission, and then what is coming next winter. For me, it's like October, I'm always in alert that, okay, what if my son gets sick? Is beginning of RSV and flu season again. And I'm talking about 8 years later of my NICU stay.
Absolutely.
So I thank you so much for pointing that out, the importance of really looking into the family's stress, because it does affect the whole family emotionally, mentally, physically, financially, and I can go on and on with that. So obviously you know me by now. But Dr. Paes, I have a couple of questions for you that came on our private chat. You talk about the most concerning age for infection is between 4 to 6 months.
Right.
Yet you talk about the continuing concerning children 2 years. This person is just asking for some clarification on that.
Right. So I think this is a very important point. So the highest incidence is in those children less than 6 months of age. And that is why majority of the guidelines for RSV prophylaxis, if you look at the preterm population, target the infants who are less than 6 months of age at the start of the RSV season. The issue is, you are correct. Some of that extends beyond 6 months of age, as I've shown to you, and maybe even up to 2 years of life. The problem is that palivizumab comes at a cost. And if you continue to give prophylaxis to these preterm infants beyond 6 months of age, then it becomes very costly to the healthcare system. And that is why you offer the protection during the key time period of infants less than 6 months of age. But we do appreciate that that risk still exists. And of course, the parents need to recognize that because they need to offer prevention strategies that we know that commonly are very beneficial, such as good hand washing, all the things we talk about, not smoking in the home environment, looking carefully at where you bring these preterm infants, especially during the winter months. And I think that's important to appreciate. But parents often ask us, why do we restrict it to only those less than 6 months? And it is because of the cost. And also to recognize that epidemiologically, the incidence of RSV, as shown in all those slides, gradually declines as you get older. And past 2 years of age is also very, very low. Although it remains relatively, I would say, still on the cards between 6 months and 2 years of age, you also need to recognize that once you go past 6 months, it is likely that the child gets exposed to RSV a couple of times, and so also develops a nice immunological response. The more infections you get, and some of those will be very, very minor, like just an upper respiratory tract infection, you develop an immunity. So it makes good sense to protect these premature infants during the phase that they're most vulnerable. And that is why the 6 months cutoff.
Okay, so another comment here. Can you clarify very preterm infants, very high risk in first few months chronological age, as you show in the slide, yet so many are still in hospital?
Right. So all of these children who are still in hospital during the RSV season, the expectation is that the healthcare providers will in fact take the necessary precautions to reduce the risk of RSV. So majority of these very low birth weight infants are within a controlled environment in incubators. Okay, once they come out of the incubators into an open environment, then in fact they do have a risk of acquiring RSV, especially from visitors to the ICU and especially during the winter months. So in some centers, as soon as these children migrate from an incubator setting to an open cot setting, they get their first dose of RSV prophylaxis. And majority of the time, this occurs when the patient, once they get into a cot setting, the majority of these patients leave the intensive care unit and are transferred to secondary level care units. So once they get to the secondary level care units, they're also in a protected environment. That exposure is still there, but hopefully it is less if all the healthcare providers and the parents take the necessary precautions when they come to visit their infants. So that is why we suggest that the first dose of RSV prophylaxis is given at the time of discharge. However, I do know that some centers start prophylaxis earlier, as soon as the child comes out from the cot into the out of the incubator into the cot, and that's fine to do, except to recognize that if you're going to do that, you still are not allowed in majority of healthcare systems to give more than 5 doses for the entire RSV season. As long as you abide by that, then I think it's fine, depending upon how you implement RSV prophylaxis for these preterm population. Yeah.
Absolutely. Dr. Paes, my other comment is now a lot of families are living in ICU during RSV season in the midst of a pandemic. How important it is for those families to go out and get their prophylaxis injections if they qualify?
I think very, very and highly important, because if you look at overall the incidence of RSV in the community versus coronavirus, which is our COVID-19, the incidence for COVID-19 is relatively low compared to the RSV hospitalizations and RSV incidence at a community level. So just before COVID broke out, in fact, there was a nice publication from Jonathan Mansbach in Boston, looking at hospitalizations for all the various viruses in children who acquired bronchiolitis. So we are talking about lower respiratory tract infection. And overall, the incidence for RSV was approximately 69 to 70%, versus for all the other coronaviruses, excluding COVID-19, because it was just coming into being, was around 7%. So it emphasizes to you very strongly that, in fact, RSV remains the dominant viral pathogen that causes serious illnesses in these babies. And I would strongly emphasize that the parents work in conjunction with the healthcare providers in each institution to safely administer the RSV prophylaxis, under control, in a controlled environment, so there is no great exposure to the baby during the time of receiving the prophylaxis. But it is very important. It's a great question. And I like to stress that because we're coming into the RSV season.
Thank you, Dr. Bosco. What a great presentation. I'm sure I will need to bring you back next year because I have a lot of more questions for you, but thank you so much for today. I'm very grateful for your time and doing this presentation for us.
You're welcome. I had good fun presenting.
And I just want to remind that Marianne Brack is our next speaker. She's going to talk about a survey that CPBF conducted earlier this year to understand parents' knowledge of RSV and common inter-illnesses. And as Dr. Paes said, prophylaxis is not available to all babies born preterm, especially the late preterms in Canada. So what can you do to prevent? And you as healthcare professional, what do you need to do to educate those families on the prevention side? And if they qualify for prophylaxis, what do they need to do and where do they have to go? So we also have on our website the criteria by province in Canada and which babies are eligible for the prophylaxis. And I want to thank you, all of you, for joining us here today. I want to thank AbbVie and Pampers for the ongoing support to make this week a reality for us. And CPBF is a registered charity, and 100% of all donations received this week will go to our educational programs for families. To donate, please go to CanadianPremies.org. It takes only 3 minutes of your time, but will make a huge difference in the life of the families that we serve.